Hello. Yeah, thank you so much for an excellent talk. Now we have the next speaker. Could you
We'll move to the last talk of the session. It's about Tirzepatide with Semaglutide, evidence from head-to-head trials. Speaker is Professor Seshadri. He is an American certified endocrinologist. He is currently working at Chennai. He is a member of Board of Management of SPV University. He is a research scholar. He has vast experience in the field of management of diabetes. I think over to Professor Seshadri.
Thank you very much. Thanks, Jyoti. This has become an annual event for me, and I really enjoy being here. And I'm the odd man around between two wonderful ladies who've spoken before me. Hopefully, we can get this done, and then we'll have enough time for some discussion because I'm sure there are a lot of questions. So the big question is, of course, people have talked about this. So I think both Nandita as well as Pramila talked about it. So I won't spend too much time on it, just a little bit of the basic science that will help us understand. And so the most important thing when you compare semaglutide versus GLP-1 is to see, is there any difference in the action that makes, let's say, Tirzepatide, as we know, give you a greater degree of weight loss? And does it give you a greater degree of waist loss? Meaning, it affects two things. One is, these affect the weight. They also affect the weight distribution. The simplest way to think about many things is to understand what happens when you lose fat. The way I think about this is that if I lose 15% of my body weight, I lose 30% of intra-abdominal fat. When I use 30% of my intra-abdominal fat, I use 66% of hepatic fat. So the loss of fat generally starts off with losing intra-abdominal fat. So that's the most important reason why you see the tremendous amount of waist loss. When I talk about this evening, understand that redistribution can occur even without weight loss. That's with pioglitazone. Right? So this is something you want to understand. Now, GLP reduces food intake. So you know that this is occurring at the level of the brain. Don't worry about the point. All right. There is a pointer here. So, one, there is an orexin-anorexin imbalance in the brain. And Pramila talked about something very interesting, that there is actually a change in the hedonic inputs that occur. The hedonic inputs do not seem to matter anymore. That means that normally what happens, you see food, your indriyas claim food, it overrides your mana, it overrides your chitta and your viveka. The fancy Indian words for all the fancy words that the Westerners use, right? But what really happens is it creates a discontent between the temptation that is created when you see food or smell food or hear food. Correct? So that viveka comes in without you applying your mind. So that's the most important part. And therefore, and then it increases satiety, that increases nausea. That's because of an alteration of the incretins, and it's feeding to the brain. In the pancreas, there is increased insulin secretion, and there's a difference between GLP and GIP, which again, Pramila as well as Nandita pointed out. And GLP causes delayed gastric emptying. On the other hand, the GIP activity in the brain, we need to be very clear that we have a lot more rat data than in terms of human data, but we know that there is a reduced intake, maybe a decrease in nausea. There's increased insulin secretion in the pancreas, which is, you will see in the SURPASS one, which I think, which showed a greater degree of insulin secretion, predominantly first phase insulin secretion, that is GIP mediated. So this is something you want to understand. Then, in the there is an increase in glucagon in a glucose-dependent pathway that prevents, so at the highest, GLP goes up, at the lowest, GIP goes up. This happens. Then, in the adipose tissue, the most important thing in the adipose tissue is that there is a redistribution of the adipose tissue, meaning the subcutaneous adipose tissue gets strengthened, the vascularity to it increases, so greater amount of fat is stored in the subcutaneous adipose tissue that prevents fat from becoming ectopic and therefore reduces complications. This is what GIP adds to it. Now, although this is not part of the slide, there is something else that Tirzepatide has which increases its activity of GLP-1, which I will show you in the SURPASS study, and that is because of a phenomenon called biased agonism, meaning it reduces the beta-arrestin recruitment. So remember, when a GLP-1 acts on the receptor, it recruits cyclic AMP that increases insulin secretion. But also beta-arrestin is something that gets recruited. And when that gets recruited, the GLP-1 that is internalized, the cyclic AMP that's internalized, gets destroyed. Therefore, it acts for a shorter period of time. But when beta-arrestin is not involved, cyclic AMP acts for a longer period of time. Therefore, a greater amount of insulin secreted. For those of you who are interested, there's an article on this in the IJCMD, which I have written. You can take a look at it. But so what really happens is that one, there is GIP action, but also there seems to be a greater amount of GLP action itself that is triggered by Tirzepatide. So these are the reasons why, as you will see in the head-to-head studies, that there's a greater weight reduction, greater glucose reduction that is seen with the Tirzepatide molecule. So I've given you a preview of what happens when you compare them. Now let's see if it really happens. So this I talked to you about. I won't spend time on it. The GIP is the one that contributes to a greater degree of glucose secretion, insulin secretion. Therefore, there is no wonder that the GIP is creating a greater degree of HbA1c reduction. Then, so should you consider it? We won't spend time on this. Let's go simply into head-to-head. The one trial that looked at, this is an obesity indication, therefore a higher dose has been compared. This is comparing Tirzepatide. The word MTD means maximum tolerated dose. If you see the initial studies, you will find people being pushed to 15 milligrams, pushed to 2.5 milligrams. But in subsequent studies, you will find maximum tolerated dose, which means for Tirzepatide between 10 and 15, for Semaglutide between 1.7 and 2.5. Remember, we're looking at the obesity pathway here. So this is the amount, this thing. You'll find that Semaglutide, this is a 2-week screening, a randomization, right? And people were pushed up to a maximum of 1.7 or 2.4, depending on what they tolerated. And here to 10 or 15, depending on what they were tolerated. So here is a head-to-head trial that is running for 72 weeks. The primary endpoint is percentage change in body weight from baseline to week 72. Fair enough? Everybody's clear about this? Move on? Okay. So let's see what happens. Can you see that these both act very early? But you can see the curves separating around the 4th week. Remember, around the 16th week, this is the, if you go back, you will see it is by around 16th week, you would have reached the maximum doses, about the 20th week, the maximum doses of Semaglutide, and around the 20th week, the maximum doses of Mounjaro here, right? And then you will see that since randomization, round about the 20th week, you already have seen a significant separation of the curves, going all the way, and around the 72nd week, this is metabolic surgery numbers, is 20%. I don't use the word bariatric. I think, please don't refer your patient for bariatric surgery. Refer them for metabolic surgery, which is different from the usual sleeve gastrectomies that people do. This is 15.4% versus 21.6% at maximum doses, both impressive. Remember, both are enough to get your hepatic fat down to 66%. But this is tremendously different. And you can see why. I already told you why it is different. The added GIP action and also the biased agonism that is occurring. So this is what you see. And let's see if we can tease out some more data from it. Now, what is really happening? The average weight loss is 17%, but is there a subgroup of people who have greater weight loss? Now, the number of people who have had 25% or more of weight loss is at least double that of Semaglutide maximum tolerated. Remember, not 2.5, not the same, maximum tolerated dose. And pretty much the same amount for greater than 20%. So two things. One, there's a greater amount of weight loss and a greater percentage of patients who have a greater amount of weight loss. So 2 learnings from this. Then let's see, go to the next step. Now, this is the bigger point. Remember, more than the BMI, what correlates significantly with cardiovascular outcomes? It's your fat distribution. And here you are seeing, again, semaglutide itself is very impressive. But here is an additional 6% or more of waist reduction, which means that you get an entirely new wardrobe and you look different. Okay, so this is the data for obesity. Head to head, greater amount of weight loss, greater percentage of people who have higher weight losses, and greater waist circumference. Everyone's clear about this? Head to head, no, and both RCTs, so there's no question of saying this was done this way, that way. Now, let's look at the glucose reduction. Here, the caveat is we are comparing tirzepatide with 1 milligram of semaglutide. But what is interesting is to see what happens in glucose reduction doses. And remember, I already told you what is happening. That there's a greater degree of first phase increase in GIP that's pushing the glucose out. And of course, the bias agonism, which creates a more sustained amount of glucose reduction. So look at this. This is surpass 1, looking at 5 milligrams, 10 milligrams, 15 milligrams versus 1 milligrams of semaglutide. So almost 4 arms. Overall A1C is 8.3, not the 10 that we see. But long duration of diabetes, which means that these drugs work at that time. BMI is this thing, and about 1,800 patients. Look at this, very interesting. So this is semaglutide. 1 milligram. And we were to look at an equivalent dose of tirzepatide, that would be 5 milligrams. Right? And you will see that the lowest dose of tirzepatide has greater glucose reduction than the average glucose reduction dose of semaglutide. So clearly you can't say, are we comparing apples and apples? Absolutely. So minus 1.9, minus 2.1%. And the glucose reduction, almost 2.5% at the 15 milligram dose. But if you really want to compare apples and apples, minus 1.9, minus 2.1. Doesn't take away anything from semaglutide. Remember, the way I look at it is, all of these are important members of our armamentarium. Sometimes you need an Indra, a Brahmastra, sometimes you need a Vayuastra. Choose the patient based on what they require. You can choose based on the company you like, but more importantly, choose based on the patient that you want, right? So, again, the same thing that you see. And A1C less than 7, this is a GLP-1 RA phenomenon. Greater numbers of people reaching an A1C less than 7. But the differentiator comes here. The higher the dose of Mounjaro, and again, look at what you're looking at. If you look at 5 versus this thing, a significant percentage of patients reaching an A1C less than 6.5 with even 5 milligrams, but at 15 milligrams, 87%. The biggest kicker is this one, showing the difference in that we physiologically have predicted. Greater GIP action leading to greater glucose production. Biased agonism creating greater GLP-1 action at both places. Therefore, that slightly enhanced behavior. So, this is the weight reduction with this particular study. Again, looking at 1 milligram of semaglutide, which is there, versus 5 milligrams of Mounjaro, about 1.5 kgs with a difference at this point of time. But when you up-titrate it, you will see what is happening, right? And this is at 40 weeks, which means exactly what I told you, that at the highest dose, the greatest difference, but that's not a fair comparison for glucose. So we will leave this. What I'm going to tell you is this. 1, head-to-head, at the maximum tolerated doses, the greater amount of weight reduction. At the maximum tolerated dose, greater amount of waist reduction. at the maximum tolerated dose, greater percentage of patients achieving greater amounts of weight loss and keeping it there. At the equivalent dose of 1 milligram for glucose reduction, greater glucose reduction, greater A1C reductions, but also at the higher doses, a greater number of people reaching normal A1Cs, which is something that you want to look at it. I think Pramila has really done a great job on adverse events, but let's compare it pretty much equivalent, right? One of the things that I would have expected is, with the beta-arrestin thing, a lower amount of nausea. That's not seen in the studies. So just everything. One of the other interesting things is that I would have seen a little bit of the constipation down with the Mounjaro bit. We have to look at Indian data. But one of the interesting things that I've seen with patients is a greater amount of diarrhea being reported than constipation with the Tirzepatide. I don't know how many of you noticed that diarrhea is actually a more that's simply because the GLP-1 causes delayed gastric emptying, the GIP causes gastric emptying, right? Nothing to separate out these two. So here we have two fantastic drugs, and hypoglycemia is similar, pancreatitis similar, just to understand. Here we have two blockbuster drugs. They have changed the way we think about obesity. Head-to-head, Tirzepatide seems to have greater weight loss, greater waist loss, greater amounts of people reaching greater amounts of weight loss. Head-to-head versus glycemic control, greater reductions in A1C, greater numbers of people reaching A1C greater than less than 7, and at the higher doses less than 6.5, less than 5. That's all it is. Choose what you want, but it's fun to have two fantastic drugs pitted against one another. So that's my job. Now I'm going to let the other two ladies come in for the discussion. Thank you so much.
Thank you, Dr. Seshadri,
Nandita,
for an excellent talk. Now I can invite the other two speakers also, and we can have a panel discussion.
come here.
Okay. Kindly introduce yourself and then ask the question.
Where is the photographer, yeah?
No, it's on. George Abraham from Chennai. Very enlightening talk by all three. I'm a nephrologist for the last 45 years, practicing nephrology in different parts of the world. Lately, for the last 1 year, I am interested in weight gain in my post-transplant patients. Okay. You elegantly talked about the medications which can be used, but my worry is that how do you assess that? I have a small device called a wearable BCM, which costs 16,000 rupees. I have been using that in my OP for my transplant patients whenever they come. It gives you the fat mass, it gives you the lean body mass, excess water. So why don't we have it used by our own people in their clinic so that each patient can have a profile, and while using these medications or lifestyle, which will help you to see how much they are gaining or how much they are losing weight. Thank you.
Yes, excellent point. Any other questions?
I think.
That was a comment. I think he wanted everybody to have a BCM monitor so that it can be, effective monitoring of the patient's weight gain. Okay, since we have no other questions.
There are enough questions.
Okay.
Yes.
To get the full benefits of GIP, beta cell preservation is required. So at a higher A1C, when the beta cell loss is anticipated, does injectable semaglutide and tirzepatide, will there be any benefits, or benefits will be almost equal?
Okay, can I take that? Yeah. So, first thing to understand is that the beta cell is probably not lost.
That's what
It's stunned, right?
benefits of
Second,
high-
I'm coming.
yeah.
Second is, remember that there are two pathways for beta cell stimulation. One is your traditional calcium channel pathway. The second is the EPAC-based GLP-1 receptor, which actually works through another pathway. So which means that is one of the reasons why the GLP-1 receptors as well as the DPP-4s to a certain extent continue to work even when your traditional indices of beta cell function, like the proinsulin-insulin ratio, come down, which means that they are able to activate another pathway, and therefore glucose control, even at later stages where we think that beta cell function is down, is activated by these pathways. So clearly we don't have to worry about that. You want to add?
The hot seats are placed for
No,
you.
we like it cold, but you can sit. You want to add? Just we'll stand around it. Yeah.
So I'm just going to make sure I got the question right first. The question was, does
The benefit,
Mounjaro or dual GLP-1 GIP or a GLP-1 agonist work in patients with secondary beta cell
not
failure?
working. The benefits of GIP, to get the full extent, beta cell preservation is required, at
Yes.
least a significant amount.
So what
at
is
a
the
higher
role-
A1C, when the beta cells are lost significantly, will the benefits
not.
of
They are stunned.
injectable-
There's just a stunning of the beta cells. They recover over, once the HbA1c comes down, there is a recovery. So it is initially at that point of time when you have the patient who comes with a severe hyperglycemia,
There is no secondary
that time
beta
there
cell
is stunning. But over a period of time, it comes back. So what you are trying to say, will it work at that time?
Will it be benefits of?
Yes, it is,
Will
it
it
is.
be equal, or
So-
will it be?
It
So
will
when
be
you-
more.
benefits
It
of
will be
tirzepatide?
actually more scientifically if you see, theoretically, because the reason being, see, when the hyperglycemia is there, we are getting dual benefit. One, you are getting a direct cardiometabolic benefit as well as the reduction of the glucotoxicity. So it will actually be very effective even at higher HbA1c levels. It will benefit there also, and even at lower levels. It's not that it will benefit there more.
Question-
We got your point, sir. Let me answer this. Remember, there are two parts. One is your quote-unquote non-responsive to sulfonylureas, which we think is beta cell failure. Actually, it's not. There is a second pathway involved that the GLP-1s activate. So which means that our traditional view of beta cell failure itself is flawed. You got it?
No, what I mean
If I
is,
could
with
just
the
add one
benefits
point.
of-
Wait, let us hear it.
Will the benefits of Wegovy versus Tirzepatide at a
Differ.
higher
We don't-
A1C
we don't know
in
that.
obese patients,
I think
will
I
it
might,
be equal,
I
or
might be able to
will
answer.
The Tirzepatide
No, I think we got
still
your
hold
question, yes.
better?
So I agree to what Dr. Krishna and Pramila are saying. Yes, beta cell dysfunction is probably not exactly what we've been looking at. But beyond the beta cells, what these incretin-based drugs also do address is also the alpha cell hyperglucagonemia. And that also is one of the major pathophysiological features which we cannot address with any of the other agents. So I think that will partly answer your question, even if the
but
beta
what
cells
is-
are
So
stunned.
can we take this offline because there are other people waiting? I'll come back to you.
Yeah.
Yes.
I mean, I have a practical question. A patient who's already on semaglutide 14 milligram, he want to convert it to a tirzepatide. At what dose he will take?
What dose is he taking?
14 milligram.
5 milligrams.
Yeah,
5.
from 14 to.
Morning, sir. It was a wonderful session by the three of you.
Use the
I-
mic, please. So use the mic.
No, she is on the mic.
So, to you, sir, straight away, when we talked of the adverse effects related to Mounjaro versus semaglutide, there is a lot of injection site reaction in the Mounjaro arm, 8.6 versus 0.3. So, how bad were the reactions? Just to get
None that, if I remember right, I don't know if the Lilly guys are around, none that were required for the patient to be discontinue the
Yes.
drug. That is what I know
Yes.
from the study.
I mean, the reaction can be as simple as itching and redness to as bad as some kind of infection or abscess.
But in most of the clinical trials with tirzepatide data, if you see, hardly, there is no patient who was discontinued for the injection site
No,
reaction.
ma'am, I just wanted to know what kind of reaction.
It's mostly the pain, the little bit of the redness that was documented, and little bit of the pain for few minutes after the injection. That was the major side effect.
Honestly,
Is the
I
Lilly
haven't
Medical
come
here?
across.
Lilly Medical is here?
No, none
Can
was
you-
very severe.
One
to cause
let
any
Lilly
allergy.
Medical answer that question, please.
Hi ma'am, I'm from Lilly Medical. So ma'am, all the events were mild to moderate and none of them were actually causing discontinuation. And as per your question, it was mostly erythema, pruritus, etc.
Yeah.
Sir?
So I want to ask you, how do you decide whether to use semaglutide or Mounjaro, and what is the expectation from the glucagon agonist which is going to come, the triple agonist? And the other question I want to know, how does the glucagon level come down with SGLT2?
Okay, I'm just going to check with Lilly. is this a scientific exchange or is this a... Okay, so I can't do the glucagon triple agonist. I can't answer that question. I'll do it outside. Let's look at these two. Generally, at this point of time, eeny, meeny, miny, mo. Okay. Pramila, you want to take that? No. Sir, actually, at this point of time, I don't know if there are any clear separators of who should go on this versus who should go on that, right? We have one study that two studies that compare it. There is also a very nice meta-analysis that was published. Third, a large study that was done in Spain by a European group that shows different patients. What can guide you? Greater weight loss required, I think, Tirzepatide. Greater glucose reduction required on a maximum tolerated dose, Tirzepatide. Anywhere else in between, I think it's just a toss-up between the two of them. But if, for example, I need 20% weight loss, Tirzepatide clearly shows. I need 2.5 milligrams reduction in HbA1c. Tirzepatide clearly differentiates itself. In the intermediate ones, I'm not so sure.
I think between the two, clearly we have, Tirzepatide has an edge over being a dual agonist. And when we, if you sort of compare the two head to head, the device is different. Here you have a vial with a syringe with Tirzepatide, whereas Wegovy is an injectable pen. And one pen has 4 doses which last for a month. Here you need 1 vial every week. Cost is almost comparable. But when it actually comes to clinical outcome, I think Tirzepatide being a dual agonist and like Dr. Krishna was saying, I think probably has an edge over injectable Sema at any given point of time.
The SGLT2 over glucagon. SGLT2 and glucagon.
SGLT2 inhibitors will increase glucagon levels because there's alpha cell, that SGLT2 receptors are present in alpha cells. Therefore, SGLT2 will increase glucagon.
So thanks all of you and Dr. Jyoti. I had a question. I am Dr. Kastava from Jabalpur. Let's say if I start these drugs on a BMI of 29, the BMI obviously will come down to 24 someday. And then there are other options for as an anti-diabetic agent. So should I withdraw and then introduce the other economical options?
No, actually that's what the data has showed, that with the amount, when we have followed up, they have followed up the patients up to 88 weeks compared to the patients who continued, compared to the patients who did not continue the drug. So there is going to be a weight gain which will happen. So if you will shift your patient to other drugs, which probably would be a DPP4 inhibitor, would be probable SU as well, alongside with the other drugs which were like metformin, suppose was continuing, your patient will definitely regain the weight. So what we counsel the patients is to continue the treatment, but there are a group of patients who will stop. So what you can do is when you follow up, you can shift them to SGLT2 and metformin and those DPP4 weight neutral and little bit of the weight losing drug, so that the weight regain does not happen too much. But if you give SUs and all, definitely you will expect some amount of weight regain to happen, more than what is expected after stopping the drug, even over and above that. So normally we counsel to continue, but there will be a weight regain as shown in the SURMOUNT-4, the data which I showed at 88 weeks.
And what about this beta cell stunning effect which would have reversed with lower BMI?
Yeah, the beta cell stunning will reverse, but that is why we talk about diabetes remission. That is the concept. So there will be there are so many factors. It's not just one factor, but what we were talking about, the hyperglycemia, at that time there will be a stunning which will reverse. So that is okay. The hyperglycemia component will be taken care to a great extent, but not the weight loss component. That lean mass which was lost, the fat mass which was lost will pick up again. So that is the component which we are trying to work on, because we are not just solo using it for the glucocentric approach, we are using it for the metabolic and the weight loss approach and the cardio-renal benefit. So that cardio-metabolic as well as your weight, that benefit will go off and the weight regain will happen, and again the beta inflammation will increase because of obesity coming back again, and again your beta cell function will decline.
So can I give you a contrarian view?
Yeah.
And that is this. You look at the SURMOUNT-3 data, what is the maximum weight gain at the end of 88 weeks was 19%.
Yes, 19%.
Which means that not everyone will actually gain all the weight back after you stop. Which means, despite what Lily or anyone else wants to tell you, there is a subset of patients who can probably come off it and stay off it with adequate lifestyle, exercise or additional medications. That is the corollary of all of this. But the majority of patients who think that the medication is an entitlement, we need to counsel that if you come off the medication and you continue to do what you think you have to do and not have the discipline to control your life, you will get back to where you were. I think that is the message from the Surmount 3 to a large extent. But is there a small subset of patients who can get off it? My hunch is it probably can.
So one last one.
question.
About
One
pancreatitis.
minute.
Yes,
Let
sir.
Dr.
Yes,
Kashinath ask.
Yes, sir. Sir, all three spoke very well. Listening to you people, I feel like starting this molecule from Monday onwards.
I'm increasing my charges.
But my question is, what is the discontinuation in 10 to 15 days? I'm not telling 6 months or 1 year. How many patients they discontinue? May not be due to cost, because of other factors like nausea, vomiting, or whatever it is. Discontinuation.
Eli Lilly doesn't have that information as far as I know. First 2 weeks. Do you have it? No. There is for Surpass 1. If I remember right, there is for Surpass 1. Let's put it this way. This is the way I look at it, and both of them can contribute. One is that the most important way is to help your patients somehow stay on it for 2 weeks. They will call you and you need to say, you want to take this? Eat slowly. Whatever you're averse to, don't take it. It's just a question of walking them to the 2 weeks. I don't know.
Yeah, so I think key is how you initiate, sir. So initiating at a lower strength and then gradually building it up and not rushing it, number one. Number two, advising the patient. I think patient education goes a long way, priming the patient on what to expect. So like sir was saying, telling them that this is a drug that is going to cause some amount of loss of appetite and nausea. Sometimes you have the wife coming back and saying, doctor, you've given him something, now he doesn't enjoy my cooking anymore. So telling them to understand that there is going to be some loss of appetite, and if earlier you used to have say 5 idlis for breakfast, now you will be having 2 idlis for breakfast and you will be satisfied. So this is a drug that is going to cause that effect. Starting with a smaller strength, 2.5, or if it is Wegovy 0.25 or 0.5, and then building up gradually over a period of a month or 2 will actually help to sensitize the patient to the drug more efficiently and help us to build to higher strengths and increase their reduce the dropout
So
rates.
Nandita, you need one second. Nandita, you need to tell me if Mounjaro causes spousal disinhibition. No husband ever tells his wife the food is bad. If he does it, then there's a problem with it.
The husband is not saying so, but then him not eating 5 idlis is an insult to the wife.
Sir,
So just to add, sir.
Madam,
Yeah.
can we add small amount of anti-emetic like
Yes, you can.
citron
Yes, you
or
can.
You can.
that?
So just to add that when we start the drug, the practical experience, what we have been doing is, first of all, tell the patient to not eat a very heavy fatty meal, not go to parties and do binge eating, because what we saw in the clinical trials as well as real world practice, because what we have seen is the moment these patients go outside, they will call and say we have diarrhea or vomiting or nausea. So that is the one thing which we can counsel them. Still, in spite of all these, there will be some 5 to 10% patients who will discontinue in the initial weeks itself. Maybe not the cost is the reason, it's just because they don't want that loss of appetite. Not that because they had side effects because of which they want to, but that little bit of nausea or loss of appetite or not being able to eat what they were eating, they might decide. So that discontinuation is even there in the real world practice as well.
Okay, thank you. I got the right answer.
So there was one pancreatitis related recent controversy on Mounjaro. That's what I want to listen from you.
I saw the DKA one, but is there an increased risk of pancreatitis?
A recent controversy.
Yeah,
It
there
is
was
something
one
that has
case
been
report
around.
which came of necrotizing pancreatitis.
Pancreatitis.
That is what you are talking about. But see, there are so many. Now that case report was published where they said that patient took this drug. But we also have to understand that overall in diabetes itself, the pancreatitis incidence is higher. So whether we can actually attribute that necrotizing pancreatitis to tirzepatide, I'm not very sure. That case report was published, but that was only one case report which was recently published. But that is only one. So as of now, in our clinical practice, till what we have been using, we haven't seen. Overall data has not shown much increase or anything to be alarming.
So,
chronic alcoholic, patient hypertriglyceridemia, previous history of pancreatitis, don't use this drug.
by the way, you don't have to do amylases before starting the drug. You don't have to do lipases before starting the drug. But if the patient has a history of pancreatitis, I still do not use any GLP-1 RA GIP combination. Ma'am?
Hi, my name is Dr. Rebecca Philippos. I'm a student of Dr. Georgie, sir. So my question is, it is written that the safe period in a pregnancy is 2 months.
Yeah.
Do you have any personal experience with pregnant ladies that you...
Having said that, there are many people who will be using these drugs, right, who will suddenly find themselves pregnant simply because they lose weight, and these are now called Wegovy babies and Ozempic babies and maybe Mounjaro babies. So far, no one has found anything untoward happening, but being a smart practitioner that you are, if a patient is planning a pregnancy, stop the drug. There are some patients, for example, who are referred by a fertility specialist saying, I want you to help them lose weight and then we will plan. Tell them that you have to use some degree of contraception while we are getting your weight down. So that's a smart way to do it.
Timeline.
2 months.
If I could just add one quick anecdote, just example, sir was asking about the vomiting and the diarrhea. So the importance of patient education. I had a patient just a couple of days ago who's been on Mounjaro now, and she's on stable dosing on 5 mg. I think increased to 5 mg a couple of weeks ago. Stable dosing on 2.5 and then stepped up to 5 just a couple of weeks ago. Although she knew very well what to expect, she knew it's probably going to cause GI, I had educated her on this. She went out, like Pramila was saying, she had gone out somewhere and eaten something and then started getting diarrhea. And her friend who was a doctor who was with her at the party or wherever that she had gone out to said, oh, you are now having you're having a stomach bug, and started her on an antibiotic. And on the day that she had this severe vomiting and nausea and she was very sick, what she went and did, she again took her 5 mg of Mounjaro on the same day. So I think what we need to educate her, and then of course it got worse. So she took her 5 mg and she was taking an antibiotic on the side, assuming that it's a stomach bug. And she was again continuing to vomit, and diarrhea was happening the next couple of days in spite of the antibiotic. And then she came to me saying, doctor, I'm sick, I have a stomach bug, I've got a
11:15.
So I think what we need to remember is to educate patients that if in this particular scenario, if this patient had come to me while she had the diarrhea, the best thing would have probably been to step down to 2.5, not discontinue, but maybe step down to a lower strength. Again, customize the patient to a lower strength for a couple of weeks and then gradually increase again.
So I have a very simple test that I do. I'll give you an example. When a patient calls our office and says, look, I have severe symptoms, can I take it off? The question I ask them is, can you try this for 3 more days? Okay?
But it's once weekly.
No.
3 more
what
days?
I'm saying is tolerate your symptoms for 3 more days. So this is my simple test. Can you handle this for 3 more days? Generally, most of them will not call back in 3 days and they will say, look, I'm able to handle it, I'm fine. If they, at the end of 3 days, still feel the same way, get them in, step down the dose or discontinue, because there's a simple thing to think about. A lot of times, the second counseling, you know what, this is part of the drug's side effects. This will go away. If you want, I'll give you a supplementary Ondansetron or something else. But let me give you, do not give domperidone. Let me give you 2 more days. See if it works. If it doesn't, then we will tackle it. Most of the time, I'm not saying all the time, most of the time this seems to work.
Hi, I'm Dr. Asha Ashik from JDC Kochi. My doubt is, after the target weight has been achieved at a high dose, maybe 15, can we start down titrating the dose, or should we maintain it at the
So
same?
there's something called micro dosing with GLP-1, which is not, of course, approved or nowhere in the guidelines, but this is one of those fad celebrity secrets that people talk about. There is no guideline, there is no right or wrong, there is no black and white. It is a gray area. It is left to clinicians' discretion. But yes, once the patient has achieved their target weight loss, discontinuation, as we discussed earlier, is going to result in some amount of weight regain. And that needs to be explained to the patient. So you may need to further intensify lifestyle modification to mitigate that, or maintain it with continuing the GLP-1 or the GIP.
One quick concern I have is there any interaction between proton pump inhibitors and the use of these drugs? Krishna?
No.
Anybody?
Anyone's aware of this?
We can
no.
use it. We have used it
No,
in trials as well.
no interaction.
You can use it, no problem.
What is?
So if they miss the dose, say for example, they're taking it every Friday, and if they miss it on Friday, they take it as soon as possible, say by Saturday or Sunday, and the next dose will be on that week the next day, on that day the next week.
Don't do what you do for contraceptives. Don't take 2 doses. Yes. Not recommended because centrally acting, right?
I wanted to ask a question. While we've discussed all the other gastrointestinal symptoms and effects, what about constipation? Do the patients come back with constipation, and how do we?
First is, I think we should not actually even call it gastrointestinal simply because these side effects are also centrally mediated. This is one.
Yeah.
Second, there are 2 reasons for the constipation. One is, don't kill me, but I'm going to say this, that people actually perceive constipation because they are eating much less than they were before, which means that they feel that, this is the amount, this is the frequency, and this is the amount that I've passed, and that becomes an important indicator of health for them. So the first thing is there's actually a lower amount of food. Second is that there is an actual constipation that occurs because of, especially with the GLP component being the way it is, that there is a decrease in gut motility. The simplest way that is to tell patients, don't worry about it. Second, you have a new rhythm, stay with it. But if in some patients, if they really want it, I use a small laxative. I don't know the others.
Because many of them will complain, but we tell them it's nothing abnormal. This is because if we explain in the beginning, they are okay. Otherwise, they'll think some new thing has happened because they tend to eat sometimes 50% of what they were eating before. But a little bit of the agents like bulk forming and all will actually help. And sometimes we use that in the beginning itself. If somebody is prone for it, tell them to take it SOS, not every day. And actually that helps. And most of the patients come out of it, I have seen in 2 to 3 months. This is only in the initial 2 to 3 months we have seen. And diarrhea I have seen actually more commonly rather than constipation in my patients, especially if they go out and eat. Once they say diarrhea, I ask them, are you out? They'll say yes.
I think we are running short of time. We will stop the discussion. Any questions? I think.
Excuse me, sir. Sir,
we'll come down and talk. We'll come down.
Out of the total weight loss, how much was lean body mass, sir? How much muscle mass was lost?
2 things. One is to remember that lean body mass is not just muscle mass. Right? And do we have the amount data? We have the percentage? So there is a very small amount of muscle mass that you will see in any of the GLP-1s, but it is not out of proportion to the fat mass. I need the exact numbers. Do you have the slide?
No, sir.
So it's not in this particular slide deck, but I'm sorry, I'll share the exact numbers when I come down. But remember that when people report lean body mass, that it's not entirely muscle mass.
I think we'll stop the discussion. If any queries are there, you can discuss anytime with the speakers. I request the crowd to give a big round of applause to all the 3 speakers for an excellent discussion. Thank you.